Endoscopic submucosal dissection for duodenal adenomas remains one of the most challenging endoscopic procedures due to the high risk of perforation, even in the most experienced hands. In this video, we describe the endoscopic strategy for the resection of a recurrent non-ampullary adenoma. In order to safely resect the lesion without damaging the muscle layer, despite the presence of fibrosis, the following techniques were used: undersaline immersion technique, use of a water jet knife connected to a pump, circumferential incision with creation of a lateral flap, clip and band countertraction at the side of the flap, and hook and drag movements of the fibrotic area while keeping the axis parallel to the muscle layer. A 70-year-old woman was admitted with a 1.5 cm recurrent adenoma in the second portion of the duodenum. Due to multiple prior attempts to remove the lesion by standard polypectomy, we decided to proceed with endoscopic submucosal dissection with on-site surgical backup. The lumen was filled with normal saline, and the lesion was demarcated in forced coagulation mode using a needle-type knife. Submucosal injection of a mixture of normal saline with indigo-carmine and adrenaline was then performed, demonstrating poor lifting of the central part of the lesion due to severe fibrosis. Circumferential incision was then completed. In particular, a wider right lateral border was created to serve as a lateral flap for traction. Dissection and trimming were performed in endocut mode due to effective energy conduction under saline with minimal bubble formation. Repeated submucosal injection and flushing with normal saline were performed continuously in order to maintain mucosal flotation and a thick submucosal space. Clip and band traction was then applied to the right lateral flap of the lesion, with the second clip placed more proximally. Effective traction exposed the submucosal plane, and the submucosal fibers were carefully dissected while keeping the tip of the knife distal to the muscle layer. However, the central part of the lesion presented a muscle retraction sign with poor submucosal lifting and tangential access to the dissection plane. To avoid damage to the muscle layer, the tip of the knife was used as a hook to grasp the fibrotic submucosal fibers. Gentle upward movement of the scope aligned the axis of dissection parallel to the muscle layer, allowing safe cutting of the fibers in endocut mode. This maneuver was repeated as needed along the fibrotic segment, always maintaining distance from the muscle layer. Finally, the lesion was removed en bloc. The mucosal defect was closed using multiple anchor-pronged clips with a drag and close technique. The patient was hospitalized for 24 hours, received high-dose proton pump inhibitor therapy, and followed a liquid diet for 1 week. Histology confirmed complete resection of a duodenal adenoma with low-grade dysplasia. In conclusion, we demonstrate a resection strategy for duodenal adenomas in the setting of fibrosis using undersaline dissection technique, clip and band traction, and a hook, drag, cut technique for the fibrotic component. This approach should be performed in centers with extensive experience in ESD and available surgical backup.